welcome to today's case study carrying on our CNS theme. Now today's video is looking at depression and antidepressants. So let's start. A regular patient of yours, 61-year-old Mrs. SSRI, enters the pharmacy. She tells you she has recently been declared as in remission from breast cancer by her consultant. She enters the pharmacy to get her prescription dispensed after seeing the GP for a follow-up regarding her mental health, specifically for depression. She tells you she doesn't think the fluoxetine given to her by the GP a week ago is working and asks your opinion. Identify the two drug therapy problems present. Now, taking a look at the prescription, we can see the patient has been given a selective serotonin reuptake inhibitor, also known as an SSRI, for depression. Now, this may be due to having the cancer itself, seeing the effect of it on her family, or some underlying, reason that we should be open to. Now, note it may also be used to offset vasomotor symptoms of tamoxifen sometimes. Now, tamoxifen is sometimes believed to be an estrogen receptor antagonist. Now, this is actually a misnomer, and we're going to see why in a second. So let's say it's a estrogen receptor antagonist that's used in breast cancer. So normally tamoxifen is given for estrogen receptor positive breast cancer. So this basically talks about breast cancer where the tumor is exacerbated or grows more rapidly in response to estrogen. Now, let's say for instance our tamoxifen acts to, like an antagonist in the estrogen receptor and prevents, estrogen from binding. So obviously if it prevents estrogen from binding, then that means the tumor shouldn't, grow, or if it's being used for prevention, any micrometastases shouldn't exacerbate or grow the tumor or cause the cancer to come back. Now, this means, if we take it as a estrogen receptor antagonist, that you're going to have a reduction in estrogen systemically, so in the rest of the body. But if you actually look, for instance, through illustrations in other areas, there's actually some protection against reduced bone mineral density, if we take an example, in postmenopausal women who are actually at risk of osteoporosis. Remember, a reduced amount of estrogen may cause effects like putting patients at risk of a lower bone mineral density and osteoporosis. Now, there's actually some protection with tamoxifen, and this is believed to be due to a partial agonistic activity, including in tissues near the bone. So what tamoxifen actually is what's called a selective estrogen receptor modulator. So that means in certain tissues or areas of the body, it may act either as an agonist or an antagonist. So it's got mixed activity depending on the area of the body. And that's why, obviously, in breast tissue, it may act as an antagonist, but in areas near the bone, it may act as a partial agonist to help reduce the negative effect, so reducing the chance the patient may get osteopenia, osteoporosis, and so on. Now, with this in mind, another important aspect where we're delving into pharmacokinetics is how tamoxifen is actually a prodrug. So a prodrug is a drug which has to be broken down into an active metabolite, and that's what has the active effect, not the initial drug itself. So if we take tamoxifen is actually metabolized by the liver via first pass metabolism, and what influences this is the cytochrome P450 pathway or the cytochrome P450 system, specifically the isoenzyme CYP2D6, and this produces many active metabolites, one of the most clinically important being endoxifen. And this is what gives us our SERM effect. as a selective estrogen receptor modulator, obviously to help prevent the risk of the exacerbation of the tumour or the breast cancer coming back. Now, this actually is important to know, because if you know on Mrs. SSRI's prescription, she's also taking fluoxetine. Now, fluoxetine actually acts as an inhibitor of CYP2D6. So what this means is you're going to get a reduced amount of the active metabolite endoxifen. This is our first potential drug therapy problem. This means that you might not have the protective effect in a patient with estrogen receptor positive breast cancer. And so that means there's a risk the cancer may come back or the tumour gets exacerbated because the estrogen can now bind to the receptor in the breast tissue. So this is an important interaction. However, note that this interaction is quite controversial due to inconsistencies in reporting. However, let's carry this on and take a look what's going to happen with this potential risk, as it's something that we really should flag up with the prescriber, and we'll talk about this in a second. So say we flag this up with the prescriber, there's different options that can be taken. One of the most common options is to try an alternative SSRI. A common one to be given is one that doesn't act on the CYP2D6 isoenzyme, and that's sertraline. It actually has very few interactions, so it's something that it's a drug that's sometimes popular with certain clinicians. Now, again, we said that it's quite a controversial interaction due to inconsistencies. However, generic national guidance in many places still err on the side of caution to flag it as a clinically significant interaction and to solve it. Now, although not technically a drug therapy problem, our second issue is connected in a specific way to the patient's understanding of the drug. Mrs. SSRI believes the fluoxetine given to her by her GP a week ago doesn't think it's working and asks your opinion. So there has been much controversy with antidepressants in terms of how reliable the evidence is, how according to many studies that come out and grouped in meta-analyses, there may have been biases looking at the data. This includes screening the impact of said drugs on patients' depression, often monitored using the Hamilton scale of depression, and in many cases clinicians are questioning the benefit to risk ratio and how the benefit may not be clinically significant. However, this is a topic still under hot debate, and so national guidance should always be referred to when looking at when or how to give antidepressants, and to always use a holistic approach on a case-by-case basis. Evidence is changing, and it's important as a clinician to ensure you're still up to date. Now, the actual antidepressant effect, i.e. the positive impact on the patient's mood, often takes roughly about 2 weeks to kick in with many antidepressants. You're probably thinking, why? Well, this draws back to the pharmacology. So if we zoom in on a neuronal cell in the brain and a chemical synapse, a lot of the basis of this stems from the monoamine theory of depression and how serotonin, one of the central neurotransmitters, may help alleviate mood and symptoms of depression, such that an increase in serotonin may help alleviate mood and get some patients potentially out of depression. Now, there are approximately 17 different types of serotonergic receptors, but we're only going to talk about some of the important serotonergic receptors. Now, let's start off with the somatodendritic area of the cell, and we'll work our way down and we'll give a breakdown. So here you have what's called the 5-HT1A receptor. Now, the 5-HT1A is an autoreceptor, so what that means is it tends to have a braking effect, usually on the calcium channel. Normally when calcium's open, it lets calcium in, say when there's an action potential present, and this allows vesicles to fuse to the membrane to release their neurotransmitter, so say for instance serotonin in this case, and obviously that can then bind to postsynaptic serotonergic receptors. Normally on the somatodendritic area, you also have nearby serotonin transporters, and these are also scattered on the presynapse, and these are involved in the reuptake of serotonin, whether that's from the cleft or from other areas. Now, obviously it's important to note that there are monoamine oxidase enzymes that are also involved in repackaging of serotonin in its degradation. Now you've also got 5-HT1B/D, which is also again autoreceptors that are involved in inhibition of calcium and thus stops the release of the neurotransmitter, in this case serotonin, and has a braking effect. Now on the postsynapse there are some important receptors. A few of these are 5-HT2 and 5-HT3. 5-HT2 include a few subtypes, important ones being 5-HT2A, where when these receptors are stimulated, all of these, you get 5-HT2A, which causes insomnia and agitation. 5-HT2C, normally when stimulated, can cause weight loss. Now remember, in depression often there's weight loss, but there may also be weight gain, but more often there's weight loss. And also the weight loss seems to be linked to, with 5-HT2C, to appetite and the effect it has on the appetite. Finally you have 5-HT3, which when stimulated causes nausea and gastric upset. So now we've got some background onto the actual neuronal cell, including the somatodendritic area and the presynapse and the postsynapse. Let's see what happens. So normally in a patient with depression, there's normally a deficiency in serotonin or monoamine, and this causes an upregulation in the number of postsynaptic serotonergic receptors, which can cause some of the effects of depression that we talked about based on some of the receptor subtypes we talked about. And obviously you can see there's an upregulation, so an increase in number of receptors. So some of these. So what we're going to try and do is give drugs which are going to increase the serotonin in the area. So what SSRIs do is they act to inhibit these serotonin transporters. So by inhibiting these serotonin transporters, serotonin can't be reuptaken, and there's an increase in serotonin. Now initially there's an increase in serotonin in the somatodendritic area. So what does this do? This stimulates what's known as that 5-HT1A receptor. Remember, 5-HT1A, it has a braking effect. So what that means is it acts to potentially inhibit the calcium from coming in, and that means these vesicles, they cannot fuse to the membrane and they cannot release serotonin. So there's a reduction in serotonin initially in the cleft. So technically it can even worsen depression initially. Now over a period of time, so this is where this part, remember it's important, this is why depression may worsen initially or may not get better. However, over about a few weeks, you get what's called desensitization and downregulation of these 5-HT1A receptors. So what happens is there's quite a bit of serotonin floating around, and obviously you've got less serotonin being secreted. The neuronal cell thinks, okay, well, you know what, there's so much serotonin here, we don't need all these 5-HT1A receptors. So it downregulates and desensitizes. So as you can see, the downregulation and desensitization. What that means is you don't get this braking effect. If there's no braking effect, the calcium channels can stay open. And so you can get fusion of the serotonergic vesicles, or these vesicles containing serotonin, to the membrane of the presynapse, and they can increase the amount of serotonin in the cleft. Now, this increase in serotonin obviously may help alleviate the depression. Now also, this serotonin, because there's such a high amount in the cleft, you get what's called these 5-HT2 and 5-HT3 postsynaptic serotonergic receptors. They actually downregulate and desensitize because they're like, okay, there's so much serotonin in the cleft, we don't need as many. So if there's less of them are going to get stimulated. So that means there's a whole lot of serotonin staying in the cleft. And hopefully that can alleviate the mood, the negative mood exacerbated by the patient. And also, remember, normally stimulation of 5-HT2A gives insomnia and agitation. So obviously we're going to get rid of that because there's going to be less of that stimulated and more serotonin in the cleft. 5-HT2C normally causes weight loss. So obviously we're going to get rid of that because there's going to be less receptor types. So obviously normally in a patient with depression, getting rid of these can be good because patients with depression can have insomnia or they have difficulty sleeping. They tend to have weight, loss, but some patients may have weight gain. So if we get rid of the weight loss, so say we stimulate the appetite, because we're not having this effect on 5-HT2C because there's less of the receptors, and hopefully you can get weight gain. And obviously 5-HT3, normally you get gastric upset and nausea, and obviously that will go. And so normally the initial amount of serotonin that you're going to get, if we have too much given initially, so say for instance we have a high dose that's not been titrated that we give, there might be so much serotonin, there's also some goes in the cleft, and not just the somatodendritic area, but also near the postsynaptic area. And so because there's that, we've already got that upregulated number of 5-HT2 receptors and 5-HT3 receptors, that's why you can get side effects. But obviously over that 2-week period or so, you can gain tolerance because you have a reduced number of the postsynaptic receptors that we talked about earlier here. That's why you can get rid of that nausea, gastric upset, the insomnia, and all of that with the drugs. So it's important to start low and titrate. Might not necessarily get rid of all of it, but there's a chance you might reduce the chance and the incidence. But obviously, this is something important to know. So obviously, as we said, this downregulation takes about 2 weeks or so before you might see that alleviation in mood. So taking this back to our patient, Mrs. SSRI, it's important to, say to her that, with these symptoms, explain to her that the effect fluoxetine has on mood can take 2 weeks or so to develop because of how the drug works. So obviously that's another week for this patient because she's already been taking it for a week, Mrs. SSRI. However, it's important to say to her, if her mood severely deteriorates, e.g. if she feels suicidal, then she should seek immediate medical attention, because there may be initial exacerbation of her depression because it can actually initially reduce that serotonin. Now, it's important to know that evidence for whether the positive effect is purely due to an overall increase in serotonin is conflicting. And certain animal studies and so on, some of them even show an opposite effect that says when there's, an increase in serotonin, it can actually worsen depression. So there's conflicting data and we're not exactly sure. And actually the discovery of one of the first antidepressants was actually by accident. There was a drug called iproniazid, which is a monoamine oxidase inhibitor. So remember, monoamine oxidase in the pre-synapse acts to degrade serotonin and repackage it into those vesicles. So iproniazid was actually an anti-TB drug, so an anti-tuberculosis drug, So they're using it to treat tuberculosis. And then some clinicians notice, hey, like the patient's mood's actually getting better. And they realize because it inhibits that enzyme, it may increase serotonin in the cleft, and they reverse engineer the mechanism, and then based off of that try to reverse engineer some antidepressants. But even now they're not sure fully, exactly of the mechanism, and some of the evidence, as we said, may be conflicting. So take this with a pinch of salt and keep a look at our guidelines, because things are always changing based on benefit to risk. National UK guidance currently recommends antidepressants usually only if the patient has moderate to severe depression, and usually we always advocate at every stage to give non-drug therapy such as cognitive behavioural therapy, CBT and so on. But remember to use your individual judgment, like looking at the past history of the patient, and you take a holistic approach. Now, with both drug therapies identified, let us move on to the patient query portion. Mrs. SSRI asks about the closest place she could buy grapefruit juice from, since her friend said it's good for the immune system. What advice would you give Mrs. SSRI, and why? Now, if we look at the prescription, based off our first drug therapy problem, it looks like the drug's been changed to sertraline at SSRI. So we've gone from fluoxetine to sertraline, maybe because of the interaction. Now, this is important to note that sertraline is metabolized by the cytochrome P450 system in the liver, specifically by the isoenzyme CYP3A4. Now, grapefruit juice actually contains a compound called furanocoumarins. So that's in grapefruit juice. And that actually acts as an inhibitor of CYP3A4. So that stops the metabolism of sertraline, so you might get an increased concentration of sertraline. This increases the incidence of side effects. And even taking 3 glasses of grapefruit juice based on a study involving Japanese candidates can increase the concentration of sertraline, thus increasing the risk of side effects. You should advise Mrs. SSRI that there are other non-pharmacological interventions and other options she can try based on this effect of increasing the incidence and concentration of sertraline. And if she's that worried about health, you can discuss different options. Well, that concludes today's clinical question time case study. I hope you found it useful. Don't forget to subscribe, like and share, and I'll see you next time.